My name is Dr. Beth Dupree. I am a breast cancer surgeon in suburban Philadelphia. I work at Holy Redeemer Health System, and I also serve as adjunct professor of surgery to the University of Pennsylvania. This is my plastic surgery colleague, Dr. William Scarlett. And where do you
I'm a
hail from?
plastic surgeon, again, work with Dr. Dupree in the suburban Philadelphia area, and I'm associate professor of plastic surgery down at PCOM in Philadelphia.
So I called Bill this morning at 6:15 as I was driving to work, having read the New York Times article on my way back from a breast cancer conference in Amsterdam. And the piece is called After Mastectomies, An Unexpected Blow, Numb New Breasts. And I asked him if he'd be willing to do a short video because I believe that some of the information in the article could be a little bit better explained, and to have the two of us be able to begin this discussion, I think, is really healthy because there are a lot of women out there who are going to be looking toward reconstruction as a potential option with breast cancer. And one of the things that really struck me in this article, Bill, was when they said that doctors often promise the patient's breasts will look even better than they had before. What's your take on that?
Yeah, again, I think the most important thing when you're talking to somebody about reconstruction is to explain to them that you're not going to create a natural breast. You're going to do the best that you can to have it looking the way that they want it to, but certainly you would never promise them that it's going to be better than what they have, because it's not going to have the sensation, it's not going to feel the same. It's more of the way you're looking in the mirror, the way that you're looking in clothing.
I always tell my patients, you cannot recreate what God made, and a breast is a beautiful thing when you think about it, because it can sustain a baby, a newborn, for 2 years. It's like the perfect factory. It was created to make milk for infants, and so to be able for someone to tell a patient that they can make something better than that is completely, to me, I think, off the wall, and that should be taken off the table right away. But I don't want to lose sight of the fact that women used to get radical mastectomies, meaning the breast, the nipple, the muscle, down to the chest wall. And for 100 years, that operation was done thinking it was saving lives, when it was really disfiguring, and no one ever dies of breast cancer in their breast. So as we've progressed forward, we've gotten to a place where we do a lot of breast conservation, but even in those patients that get radiation, you see patients post-radiation, many of them have decreased sensation, they have skin changes, and some of them have chronic pain. So I felt that this was a little bit one-sided because we're not really looking at the whole picture here. So when someone comes to you for reconstruction, what do you talk to them about what to expect down the line? Do you promise them, if they can keep their nipples, that they're going to feel sensation?
Well, first you have to look at, again, we're treating cancer. What else is going to be involved in this? So can they have nipple sparing or not, depending on where the tumor is? Are they anticipating that they're going to need chemotherapy or radiation? Because that certainly can change the way that we approach the reconstruction. But assuming the person doesn't need radiation, they don't need chemotherapy, so it's just the fact that they're having reconstruction, I always tell them, even if we're saving the nipple, it's purely what you're going to see in the mirror. It's not going to, it's not going to have any sensation, any contractility. I tell them that the entire breast is going to be numb for 6 months to a year, and we found that even now, some people, 2 years out, 3 years out, are starting to get sensation back.
Right. So the bottom line with this is, breast nipple sparing mastectomy is still an evolving art. Mm-hmm. We've been offering it across the board to patients that it's appropriate for probably since about 2009, 2010. And we do get patients that get some sensation back, but you don't get the same sensation. It's not going to be the same as it was pre-cancer or pre-surgery, which was really upsetting in that article, that patients were actually expecting to have sexual pleasure and some type of an intensity that they had previously. So I think that expectation right away needs to go away. But I really think we're losing sight of the fact that we're treating cancer. We're treating a disease that in women years ago, they didn't have an option to keep their nipple. They didn't have an option to look in the mirror after mastectomy and still see the visible form of a breast.
So it's interesting, as I was reading through it, I kind of chuckled to myself in that, you hear about surgeons promising this or that. When I consult with someone on a breast augmentation, where all I'm doing is putting an implant in, the breast tissue is not being cut, I tell them that they can have a change in sensation and change in contractility, and that they could actually lose both of those things depending on the surgery and how they recover. So for someone to tell a patient who's having a complete mastectomy done, even though they're saving the skin and the nipple, that they're going to have sensation or contractility is absurd.
Right, and I know, it was very upsetting to me that the women weren't informed because I can't police what doctors tell their patients in the office. And one of the things that we hope to do through this process is to, post a list of questions that anyone who's going to see a plastic surgeon or a breast surgeon about breast cancer surgery is to ask the specific questions, ask them pointed to get answers to your question. Because these are things that come into all of what we call informed consent. And it may not change what you do surgically, but at least you're going to go into this completely with your eyes open and knowing what to expect before, during, and after. And I always tell my patients when they say to me, particularly ones having risk reduction surgery, because that is someone who's healthy, undergoing the knife, undergoing a procedure. And when we do our nipple sparing mastectomies, we try in patients that can have it to do what we call an inframammary incision, because hiding the scar can absolutely help someone psychologically, but hiding the scar doesn't change the fact that that nipple still may be insensate. And when a woman's coming to me for risk reduction surgery, I tell her, your grandbabies aren't going to care whether they're hugging fake breasts or real breasts, but they're going to care that you're there. And for women that choose risk reduction surgery, they're not doing it to try to get new breasts. They're doing it to try to decrease their risk of getting breast cancer. And in certain genes that women carry, the risk can be as high as 87% by the age of 70. And those cancers, many of those cancers are a very aggressive form of cancer called triple negative breast cancer. So when people judge individuals like Angelina Jolie and others who are in the media for choosing risk reduction surgery, you can't judge because you're not walking in their shoes. And going through chemotherapy and facing cancer is very different than doing risk reduction surgery. But for me, I really want my patients to know that they have choices, they have options. There's been a lot of information in the news about bilateral mastectomies, and I would never talk someone into having a bilateral mastectomy. Some patients choose it because they would like to have less stress from the screening process or symmetry issues. There's a whole host of reasons. And some women really need to have mastectomies because they've got multifocal disease or a large tumor and a small breast or non-invasive cancer that's very extensive in the breast. But for every patient that's diagnosed, I make them see Dr. Scarlett. I send them to see Dr. Jane. I make them see a radiation oncologist, the plastic surgeon, because we all have choices about how to treat cancer and what can be best for our patients, but we can't actually make that choice in the end.
I think it too depends on the team that you're working with. Beth had mentioned most of our incisions are inframammary when we do nipple sparing, but there are other places that they're still doing the omega incision or vertical incision, and that's certainly
what's an omega incision.
It's where you're actually going from the lateral around the upper aspect of the nipple areolar complex and then medially, so it looks like what an omega would be. That's certainly going to increase your chance of losing nipple sensation and contractility, and in our literature actually increases the chance of nipple necrosis. But it's one of those things that when you're talking to a patient about potentially doing this, just as you are with most cosmetic procedures, you have to look at the symmetries to begin with. If the one nipple is lower than the other nipple to start with and you're doing nipple sparing, it's probably still going to be lower. There are things that we can do to try to improve that, but these are all conversations that need to happen before the person decides to go forward with that sort of surgery.
All right, so at the end of the day, number one, I applaud the New York Times for taking this on because this is a big deal. Patients' expectations, informed consent are huge. I got a post on Facebook after I posted the article. This woman said her tissue expanders have been in for 12 months and they're miserable and they're hard. You ask any of my patients, and they know what I call the tissue expanders. I call them the rock monsters because it is like someone puts a boulder underneath your muscle. And for some women, they have to be in for a larger period of time because of chemo or radiation therapy. We don't always know that going into surgery. So what is your best advice for someone who's contemplating a mastectomy and whether or not to keep the nipple? What would you tell someone who's watching this video right now?
Well, again, we have to step back and look at the whole picture. Are they a smoker? Are they a diabetic? Are they morbidly obese? All of those things increase your chance of having vascularity issues.
And what does their breast look like?
True, to start with.
Whether it's ptotic, whether it has droop, whether it is whether the patient's a great candidate for breast, for a nipple sparing mastectomy or not.
Right. So again, and then it becomes, well, where do you want to end up? Because if they decide that they want to be a little more full, or we know that they're going to need radiation, and the radiation oncologist would prefer to have a tissue expander in, then we'll certainly start with a tissue expander. And we always have that as a backup, because if the flaps are looking bruised, or you check them with a vascularity device and you're concerned, you can put in a tissue expander and not put in much fluid or any fluid. But the other thing is, it depends on how you're filling that. Depending on which model you're using, you may be seeing them weekly and adding 50 cc's, or you may be seeing them every 2 or 3 weeks and adding 150 cc's.
So become educated about what
Again, you need to know, because I'll have patients come in and they'll say to me, oh, I took 2 Percocets before I came in for my fill. And when I talk to them about it and ask them why, it's because a friend of theirs had the same procedure done elsewhere and said they had horrific pain with the fill. Most of my patients, because I'm only adding 50 cc's, come in, have the fill, and go right back to work. So again, it really depends, but it can be adjusted to the patient. Sometimes we'll do 50 cc's every other week if it is bothering them.
So we need to keep this short and sweet, because I have to get back to the office. I've got biopsies to do, and I know you have patients to see as well. And because we can't be the police of our colleagues. Our job is to educate and empower you. So what I want you to do is ask the right questions, which include, number 1, if I choose or need a mastectomy, what are my reconstruction options? Number 2, what's the difference between implant-based and autologous? So could you just mention what autologous is? Because people read this in the news. They don't know what tissue reconstruction is. So real quick.
Yeah, it's just taking tissue from one part of the body and moving it up to the breast. It can be anywhere, but in this case, the breast, in order to recreate that breast mound. This will not change the sensation of the skin, but it's just using your own tissue instead of using an implant. It'll feel differently, but it also is a much more in-depth procedure, so you need to kind of look, again, at the whole picture and what it is that you're trying to accomplish.
Got it. Next question. Can I have reconstruction with implants immediately, or do I need tissue expanders? The next question is, how would chemotherapy and radiation therapy affect my reconstruction choices? Ask where your incisions are going to be located. Find out where they're going to place your scars and why. And many times the doctors have phenomenal reasons for why they do that, but just understand that going in. Can I preserve my nipple, and why? If not, why not? And I will tell you, for us, we've progressed from a place of nipple preservation where we had very, very strict criteria for the first 3 or 4 years. And as we've become more comfortable with the operation and we've learned new techniques from other oncoplastic colleagues around the world, we've added additional opportunities for patients to preserve their nipple. Next question is, will my nipple have sensation? Is it possible? And if you choose to remove your nipples, can they be reconstructed? And the answer is yes. They'll never have sensation then. And if I need tissue expanders, what will they feel like and how long will they be in? And the final most important question are, discuss and ask what the potential complications are in your case. And again, that's weighted on your body mass index, whether you've ever been a smoker, whether your skin has been radiated previously, what the actual composition of your breast is, meaning do you have droopy breasts or not, and all of those things are going to come into play. But most important thing is, get the right answers to the questions. And if you're not happy with the answers that you get, always get a second opinion, because second opinions are great. It doesn't mean that you're going to leave your first doctor. It means you're just getting a double check. You're getting a verification. And I send my patients for second opinions all the time. And I hope this helped. And thanks, Bill.
Absolutely.
He hates taking my calls at 6:30 in the morning. Take care. Have a great day.